We're going to look at gluteal tendinopathy. We're going to look at what causes it, who gets it, and a quick overview on how to rehabilitate it. Now, gluteal tendinopathy is a chronic overuse condition affecting the tendons of the glute med and or the glute minimus, where they attach to the greater trochanter of the femur. It is the most common cause of lateral hip pain, often previously referred to as the greater trochanteric pain syndrome. Now, this condition represents a degenerative or reactive tendinopathy rather than inflammation, involving collagen disorganization, neurovascularization, and an increased sensitivity of the tendon and the surrounding tissue. Now, who normally gets gluteal tendinopathy? I hate to say it, but it's middle-aged females, 40 to 60 years of age, and that is the most common demographic. It's often associated with reduced pelvic control and hip abductor weakness. It's common in runners or individuals who engage in repetitive single leg loading. It's frequently linked to compressive loading of the tendons. So example, crossing the legs, sleeping on the affected side, or standing with the hip popped out. So what causes it? Now, gluteal tendinopathy typically develops due to a combination of compressive and tensile stress on the lateral hip tendons. Now, contributing factors include excessive hip adduction, so compression under the IT band, weakness in the glute med and minimus, which can lead to poor pelvic control, increased training volume or sudden load spikes, poor movement patterns, so knee valgus or pelvic drops, hormonal changes, particularly postmenopausal women, prolonged sitting or side lying on the affected hip. So what are the key clinical features? Pain over the greater trochanter, so point tenderness, pain lying on the affected side, especially at night, pain when walking upstairs, up hills, or standing on one leg. Now, it may radiate down the lateral thigh, but not below the knee, and it often worsens with crossing legs or hip adduction postures. Now, there are many ways to test whether the individual has gluteal tendinopathy. A lot of this information will come from the subjective assessments when you talk about what aggravates the injury, when does it, where is the pinpoint, the palpation of the pain. But other tests that we can use the single leg stance test, and the patient might see pain in the lateral hip region. We can do resisted hip abduction, and this is where pain will be kind of reproduced. We can do the Faber's test, and that might provoke lateral hip pain. We can do the Ober's test, and that may reproduce pain for the patient as well. And then we got the Trenenberg test, and that can indicate gluteal weakness. Now, if a patient came in and we suspected gluteal tendinopathy, how can we treat it? So the main goal of the rehabilitation approach is to reduce pain, restore tendon load tolerance, improve hip strength and control, and reintroduce functional activity. Now let's look at how we would rehabilitate a gluteal tendinopathy problem. We split it into 3 phases. So phase 1 is load management and pain control. And what we're going to try and do is reduce the pain by reducing the compressive load on the tendon. We advise patients not to cross their legs or stand with their hip popped out. Lying on the painful side is a big aggravator. Instead, see if they can sleep on the opposite side with a pillow between their knees. We introduce isometric exercises such as side-lying abduction holds or wall presses, and this can help reduce pain and maintain tendon load tolerance. We do some gentle hip flexor stretches, but we try and avoid aggressive adductor or ITB stretching at this stage as they will increase tendon compression. Now, phase 2 is strength and capacity. So once pain is more stable, we want to progressively strengthen the hip abductors, ABD, and improve pelvic control. We can start with double leg bridges and progress to single leg bridges. We can include side-lying hip abduction, so ABD, with good pelvic alignment, and then progress to standing variations using resistance bands. We can do lateral band walks and controlled step-ups, and these are great for functional movement. Just remind the patient to keep the pelvis level and avoid letting the hip drop. We do the pain monitoring model. So up to 2 out of 10 discomfort during or after exercise is acceptable, as long as it settles within 24 hours. And then we have phase 3, so the functional and return to activity. Once the tendon is stronger and pain-free in daily activity, we move into functional rehab. So we include single leg squats, step downs, and split squats, ensuring they maintain good pelvic control and alignment. We can add hopping and running drills when strength and control are symmetrical. The focus should be on quality of movement, so no hip drops, no valgus knee, and no adduction under load. Now, some clinical tips. Remind patients that improvement takes time, typically 6 to 12 weeks of consistent rehab. Don't prescribe stretching early on. It feels relieving short term, but it can worsen the symptoms. Use isometric exercises to manage pain flare-ups, and always encourage consistency over intensity. Now, overall, gluteal tendinopathy rehab is about progression and controlled loading of the tendon, not rest or aggressive stretching. Here is just a summary of some handy hints for sports therapists that might be working with this type of patient. Teach patients sleep modifications, pillow between knees or lie on the opposite side. Emphasize posture correction and standing and sitting. Use isometrics for pain relief during flare-ups. Avoid stretching the ITB or adductors early because this will compress the tendon. And encourage consistent low load activity instead of total rest. If you want to read more about gluteal tendinopathy, here are some references that you can have a look at and expand your knowledge and understanding.